Okay, so it's Martin Kiernan here again, and it's another edition from the SHEA meeting, and I've managed to grab a few minutes with Dr Michael Klompas, who, if we tried to schedule it, as he's just said, that wouldn't happen. So we're going to talk N95 masks. Now, in the States, CDC have mandated or suggested that you should be using N95s for suspected and confirmed COVID cases, but it took a while before that happened. So why do you think, and where did the evidence come from that actually made them change their mind and start to suggest that that should be the case?
CDC's starting point actually was in favour of N95s for the care of patients with suspected or confirmed COVID, and that was a carryover from their approach for any novel respiratory virus.
Yeah, that was similar in the UK actually. They did that right at the beginning, a high consequence infectious disease.
Precisely. So that was the default. It was only when there was considerable operational challenges in the early days of the pandemic around supply, which was acute and desperate, where there simply weren't enough N95s to go around, that people started to wonder if that was the most appropriate guidance, given the sort of operational realities of if there's not enough to go around, where do we prioritize? And at the same time, I think people borrowed from conventional practice with regard to other common respiratory viruses, influenza in particular, where the standard of care has been to use a surgical mask or a procedure mask, and felt that in many ways COVID was behaving in a way similar to influenza in terms of its transmission pattern, and therefore people divined that therefore a surgical medical mask was probably adequate. And so I think that was the initial, that's what allowed for the transition.
Yeah.
And then I think the transition back to saying, well, no, N95 really is the standard of care. It's most appropriate for a COVID patient. I think it was two parallel tracks. One was the improvement in the supply situation, which fortunately did improve relatively quickly. And the other was that simply the emerging science, demonstrating with increasing clarity across more and more time that the virus is airborne.
Now, as your recent paper suggested, or your recent discussion paper suggested, many people are in the incubation period and therefore even more infectious than they are when they're actually displaying symptoms. And with a variant like Omicron around, there's that much of it in the community. They're coming into hospital with their fracture or some other medical condition whilst incubating, and that isn't the standard of care for those patients. And you're suggesting that when Omicron is highly prevalent in an area, that we should move to N95 standard of masks for everybody.
Yeah, that's right. I mean, that's the tremendous irony, is that if you look to see where does a healthcare worker get infected, it's not on a COVID ward.
Yeah.
And the reason is because if patients admitted with COVID, first of all, they are using high-level respiratory protection. They're managing those patients very carefully, and those patients tend to be at a later stage of illness when they tend to be less contagious. By contrast, particularly with Omicron, with high community surges, the likelihood of somebody being infected with occult COVID is so much greater.
Yeah.
So when we look to see where healthcare workers get infected, typically is in non-COVID areas, taking care of patients who are not suspected to have COVID or interacting with a colleague who's not suspected to have COVID. And that's why our thought is that given the limitations of surgical and medical masks, that when there is a lot of COVID around, and that you want to stop in-hospital transmission, that is the time to switch to N95s for all practitioners to both protect patients as well as to protect one another from patients and from colleagues.
And that's exactly what you've done in one of your recent studies, isn't it? You switched everybody to N95 and brought a cessation to an increasing problem with Omicron down.
Yeah, during the height of the Omicron surge, when we were having hospital onset infections basically daily, and we were noticing clusters, we created a cluster response protocol where if we noticed that there were 3 or more cases on a unit within a 3-day period, we put everybody on that unit onto respiratory precautions, which meant that the healthcare workers were wearing N95s basically all the time.
Yeah.
And we tested patients daily. And using that strategy, we were able to abort these Omicron-based hospital clusters incredibly rapidly.
Yeah.
And so it did bespeak the benefit of the N95 as a mechanism of source control as well as individual protection.
I mean, and part of the problem in many hospitals, and certainly in the UK this would be the case, is that our ventilation systems are really not that great. We're not getting a large number of air changes. I know in Australia they've had air conditioning related issues as well, and they brought in portable HEPA filters as a mitigation measure as well, but for many people that's not always that possible. So switching to N95, it's possibly a method of source control if you have it yourself, but it's also going to stop you acquiring it from somebody else, certainly much more effectively than a surgical mask.
Yeah, I think that you're rightly indicating that infection control is multifaceted, and that there are many different strategies that one can lean on to try to improve a problem. So improving ventilation is great. Often that requires massive structural changes that are simply not possible. So using a HEPA filter is another alternative. You can get sort of appropriately powered and operating for the space that it's in. Vaccination, of course, is critical. We have good data now. Vaccination decreases the risk of both being infected as well as the risk of transmission.
Yeah.
So maximizing vaccination and boostering in healthcare workers as well as in patients is helpful. But at the end of the day, if there's still limitations to one of those, the above, that the point of interaction in N95 has proven, I think, to be powerfully effective for protecting the individual as well as for diminishing transmission.
Yeah, I mean, I actually can't understand the reluctance to use them, to be absolutely honest, because you have something that you can get properly fit tested and be confident that it's going to be as effective as you possibly can do, and it's relatively inexpensive compared with the cost of losing staff due to outbreaks of clusters in healthcare workers.
No, I agree with you. I think the field is governed by a lot of inertia and dogma about the ways we have done things. I think people have associations in their minds with the N95s about the sorts of scenarios they ought to be used with, and it's difficult to frame shift and say you could use that for a much broader kind of scenario. The fit testing issue, I think, has become a bit of a double-edged sword.
Yeah. Because
it's absolutely true that to get maximal benefit from your N95, you should be fit tested. But I would say, and we have data to show this, a non-fit tested N95 is superior still to a medical or surgical mask.
Yeah.
And so if fit testing is sort of the barrier to further use of N95s, it's truly shooting oneself in the foot, because you should deploy N95s without fit testing. You'll still get to a better place than with surgical masks alone.
Unfortunately, in the UK, it's mandated that if you're using that sort of mask, you have to be fit tested. Yeah, oh really? Okay.
Same in the US as well. Yeah.
Yeah.
Then the other factor, I think, is that people are still, in many cases, are wedded to historical hard shell N95s, which are very uncomfortable to wear for long periods.
Yeah.
You simply can't do it. And the good thing is that there are many soft shell models now made by sort of first-rate companies, fully certified for performance, and they're very comfortable. I wore N95 on my flight over here, had on for 10 hours, no problem.
Yeah.
So it's entirely doable.
Okay. And do you think that people will look at droplet precautions as actually an outmoded method of transmission, and will that go? Because I'm not seeing a huge amount of evidence for droplet transmission, I have to say.
Yeah, nor am I. I think we've learned that respiratory emissions occur in a range of sizes, but most of them are in the aerosol range. All those emissions across the range of sizes can carry virus. That's true for all respiratory viruses. It's not just SARS-CoV-2. And we have good animal data and human data demonstrating that does lead to and can lead to transmission. So I personally don't see a benefit right now to the historical dichotomy between droplet versus airborne-based pathogens. And I certainly hope that the public health agencies will evolve in that direction.
Yeah, there has to be something good out of this, and there are always opportunities to look back. It's just sometimes there's an unwillingness to lose face and maybe make people think, well, they stuck to a line which was wrong all that time. Personally, I've never had any problem with saying that was wrong. We've learnt more, and therefore we need to change.
Yeah, I agree with you, and I argue that the harm you do yourself by hanging on to an outmoded set of practices in the face of increasing evidence is greater than the harm you might do to yourself by saying, listen, I wasn't quite right, and we now see things in a more sophisticated and more nuanced kind of a fashion. So yeah, I don't think we should let past errors stop us from making future corrections.
Okay. Well, thank you very much, Michael. I've really enjoyed chatting to you and really appreciate your time today. Thank you.
Lovely. Thank you so much.